Let me ask you a theoretical question. Let's say you do a bite adjustment on a patient and their face feels more relaxed instantly. Their tooth hypersensitivity goes away. In other words, they're swishing with ice water, let's say it's decreased. Their mandible kind of floats forwards. Their neck feels relaxed. What do you make of that?
Well, that's a sympathetic response.
After an occlusal adjustment, computer directed, that took maybe 45 minutes to an hour. Permanent, either very minor subtractive adjustments in the excursive movements or additive in the excursive movements. I've seen that hundreds of times.
Well, you have found a cofactor into the sympathetic part of the nervous system.
Right.
Okay, and I do want to point out that that's not uncommon. You can see that same kind of reaction after a C-spine adjustment. Okay, so a chiropractor could realign C1.
Mm-hmm.
And it's that same sensation. They get fatigued. They act like they're going to fall asleep. They may get a flushing related to that. Very oftentimes there is less sympathetic tone, so blood pressure comes down, and heart rate can go down as well. Now that's direct sympathetic input to the heart. Mm-hmm. And so you can see that kind of response. Tinnitus goes down with those adjustments. So you're in your world, what you're saying is, wow, I can adjust the teeth and get this release that's generalized in the head and neck.
Right.
The chiropractor can do the same thing. I can do the same thing. So what's the patient do? The patient addresses the factors that are most dominant. Okay? And for example, I may say to a patient, I know you have a TMJ problem, but I also know you have malalignment of C1. I also know you have a malocclusion.
Right.
Okay? So do I want to repair their TMJ? No, not until I know that we can't wind down the sympathetic pain treating the other two. Mm-hmm. Okay? And it doesn't need to be total mouth rehab. A lot of times for me it's a splint.
Sure.
Okay? And just getting him into a splint, sending him to the chiropractor, and then watching the layers interact. Okay? Now the layers, especially the sympathetic layer, comes down with the other treatment. Then you may be able to say to the patient, okay, these layers were a bigger part of what defined your pain than your TMJ.
Right.
Okay? And if we strike out with those layers, we can always come back to the TMJ and do that as well.
Interesting.
Okay.
Triaging.
So, yeah, you can triage it. You identify all the things that may be cofactors, and then you're saying, okay, what's practical for this patient to do with the cofactors? Okay, it could be a young patient, some TMJ damage, maybe a stage 4A early, and they may have had a cheerleading accident and C1 is way off.
Yeah.
Okay, that's very well the dominant cofactor, and you want to get that treated. Okay, and you can say the same thing about the bite. Here's what the general dentist has to understand though. When you think you have identified the cofactor and you've treated it, and it's a temporary resolution, now you have to look at your other cofactors.
Right.
Okay? You could still be in the bite because the bite's not fully adjusted, but I think you have to start more seriously thinking about C1, 2, 3. You have to think more seriously about the joint and what else mechanically may be driving the Cribs pain.